Mesdames, Messieurs, bonsoir, bienvenue. Nous sommes ravis de vous accueillir ici en direct de Hilton Resort à Fitness, ici que pour dérouler une CMI en direct, première fois qu'il nous peut faire à l'île Maurice, donc ce sera un CMI, un Continuous Medical Education en direct qui se fera ici entre OMCA, BLK Max et CICARE en collaboration avec ces trois partenaires. Donc, nous prenons le docteur Rayaz Ahmed qui propose le bone marrow transplant et aussi le docteur Kulbhushan Singh Dagar, le fameux médecin qui fait une opération de petit bébé Ezekiel. Donc, passons de Omka Foundation. Je vous laisse tout de suite accompagné de Poonam qui sera le master of ceremony de cette soirée.
Which is a CIE event organized by its partners on two specific topics. So today we are going to have a talk about neonatal congenital heart surgery, which will be presented by Dr. Kulbhushan Singh Dagar, and also hematology and bone marrow transplant, which will be hosted by Dr. Rayaz Ahmed. So today, to make this event successful, so we have on stage with us Mr. Taslim Dilu, the CEO and founder of Umka Limited, Mr. Tawfiq Dilu, the director of Umka Foundation, Mr. Shahrukh Khan Dilu, head of director of International Patient Services. We have on board with us on this venture Mr. Harsh Dubai, international business developer of Max Hospital, Mr. David Stanton, head of quality and medical services of CCare, and our CPD provider for tonight will be Dr. Nilambar Tushal. So without
Thank you, Poonam. Good evening, everyone, doctors, nurses, and our chief guests from India, Dr. Dagar and Dr. Rayaz. So myself, Taslim Dilu, the founder and CEO of Overseas Medical Care Assistance Limited, the UMCA Group. Thank you, everyone, to be here. It's a pleasure to see my colleagues and my doctors welcoming here to learn about some of the techniques and our experience of our doctors in India, Max, our partner. So at UMCA, our main goal is to create, we can say, the bridge between Mauritius, Africa, and India, where we can make it accessible for our patients, for our clients, and even for our doctors to be able to use and also try to have the maximum capacity to be able to learn anything that's happening in India. As we know that India is one of the largest healthcare provider right now in the world. So, and according to the price and also the amount of doctors that is available in India, if we go around Europe or even US, we will see all Indian doctors available in all the top class hospitals, even in Abu Dhabi, even in Dubai, even in Saudi Arabia. Why? Because the network of doctors and the available of doctors available in India is very, very large. Us at UMCA, we are trying to make the bridge for our doctors, for our nurses to be able to learn and try to bring what they are doing there in India and bring it to Mauritius, where in the future our patient can be treated in Mauritius itself. This is very important for our family, for our client, for our patients to have the treatment as fast as possible. So, which means that to have the treatment in Mauritius. And this is why we are bringing our expert doctors to train, to share the experience, and also to make the bridge much more easier for our clients, for our patients who need treatment abroad. And I won't be too long. I'm myself a nurse, and for the nurses, I'm going to be the CPD provider for them. and I see my colleague nurses over there also, which will be able to make whatever we can during this training and CME. So I would like to thank you very much for coming, and let's learn from this CME. Thank you very much. And let's
Thank you, Mr. Taslim Dilu. So I would also like to invite Mr. David Stanton, the head of quality and medical services of CCARE, to address a few words to our audience. Please welcome Mr. David.
Good evening, everybody, and thank you for inviting us. Thanks for the collaboration that we enjoy this evening, and for the collaboration that we established today. Two esteemed presenters came and visited us, and we explored some opportunities, as has been mentioned. Cross-ocean collaboration only brings expertise and is better for our patients. So we also are looking forward to learning this evening. And just from the CCARE side, thank you very much for your generous offer of knowledge that you will share with us this evening. Thank you very much.
Ladies and gentlemen, so tonight's event is being held with a very big collaboration of Max Hospital, without whom this wouldn't have been possible. So I would like to have Mr. Harsh Dubey, International Business Developer of Max Hospital, with whom we are having these two doctors, which will be our speakers for tonight. Please welcome Mr. Dubey.
Good evening to everyone. And we are from Max Healthcare. Max Healthcare has 22 hospitals in India. At this moment, we are number one healthcare provider in India in terms of international revenue. We are doing number one. We have done collaboration with Omka team, and Mr. Taslim and Mr. Tawfiq are helping us too much, and they have invited to you on this platform. My request to you again, if in future, if you want anything, any help like knowledge change program, so we are happy to do that. Thank you.
So for tonight, the CPD provider is Dr. Kushal Nilambo, and I would like Dr. Kushal to do the presentation of our two speakers before they start the presentation. Please, Dr. Nilambo.
Good evening, everyone, and I'm very honored to invite and happy you have accepted our invitation. We have two eminent speakers from India today. Dr. Kulbhushan Singh Dagar is a very experienced doctor in congenital heart disease and a very well-known surgeon in India. He has more than 30 years of experience, and he will be here for us to deliver his expertise and enrich us with his knowledge. And also we have Dr. Rayaz Ahmed, who is the principal director of the hematology and bone marrow transplant unit at Max Super Specialty Hospital. He also will be helping us to have more knowledge in the field of bone marrow transplant, which is not available in our country. And this will open new doors for us. And also, if anyone who is interested in the field, feel free to contact us, and we will be able to support you with the help of this prestigious hospital. I will not take long, and I will open the floor to Dr. Rayaz Ahmed for the first talk tonight. Thank you.
Very good evening to all of you. Thanks for coming and thanks for inviting us to Mauritius. This is my first visit to Mauritius and I'm already loving it. So, as for the CME, uh, I'm being told to do some presentation in BMT, bone marrow transplantation, and what hematology is. So, basically, what the hematology is. When we were in the undergraduates or the postgraduates level, when we are not even doing the super specialty of, so we used to read about leukemias, AML, ALL, and we used to wonder what happened to these people. So we used to read, okay, acute leukemia, some classifications, that's it, some few drugs. But over a period of time, we developed some interest in that. And then that's how I went into the hematology. And we are able to give chemotherapies. Now we are doing bone marrow transplantation and also the latest CAR T cell therapy. So what's new in hematology? So hematology is area of whatever deals with your blood. So blood is an organ which is being formed in the bone marrow. That is the soft part of the bone. And from there, the blood is being formed daily. It flows in the body. And the blood is not just the liquid. It contains a lot of cells. It has got RBCs. It has got WBCs. It has got platelets. Every cell has got different function. So if your cells are high, it is less, or it is malignant, or it is dysfunctional, you can have n number of problems. So blood cancer is just not one disease. It's you can say at least 1,000 diseases are there in the blood cancers. Okay, different type, different functions, different therapy, different outcomes. So you can have a blood cancer patient who will not even see 1 week of life if not treated, or 24 hours it get infected. Or you can have a blood cancer patient who comes to your OPD and we say we won't treat you, not because we cannot, no need treatment is required. So you have a patient who is being followed up from just near the symptoms to a patient who requires urgent treatment. So one way of treatment is bone marrow transplant. We'll come to that. The newer things in the hematology is immunotherapy. Previously, it was like chemotherapies, and now world is moving from away from chemotherapy to lesser dose of chemotherapy and more of a targeted therapy or immunotherapy to deal with this oncological problem. And the latest to it is CAR T cell therapy. We'll have some slides on that. So bone marrow transplant, what exactly is bone marrow transplant? So how do they cut the bone? How they put the marrow? Things. And it's like how they exactly do it, bone marrow transplantation. So I'll just go to it. It's not a surgical process. Okay. So we learn about kidney transplant, we know the liver transplant and the bone marrow transplant. So liver transplant, you need a donor. The donor is on the surgical table. You take a piece of liver, just put it inside. You need a surgical skill followed by medical skill. Same is the kidney transplant. The donor has to donate a kidney. Live donor going on the table, take a kidney, put in the patient, and both lives, but not in bone marrow transplant. So bone marrow transplant is not a surgical process. It's the only transplant which a physicians do. So what we do exactly take? We take the stem cells. It's just like a blood. So if we are donating blood, it will contain stem cells. Okay, so how do we do it? So if we have donated the single donor platelet in the blood bank, if you have seen the platelets being donated, then the same machine, we just change the settings with the stem cell donation. You collect the piece of 100 to 100 ml of blood depending on the weight and the height, and that's the stem cells which we again, just like blood transfusion, it goes inside and make a new system. So basically it was the first immunotherapy. You are changing the immune system. You're not changing the marrow. You are also changing the immune system of a patient. And that new immune system take over the body and do a lot of good things plus the bad things. We'll come to it. So it was all started by this doctor. He received the Nobel Prize, Colonel Donnell. So he was the first one who pioneered this science, you can say, and the first one to do the bone marrow transplant. Is considered the father of bone marrow transplant. Now, bone marrow transplantation, again, it can be of many types. So, two main categories. One is autologous transplant, another is the allogenic transplant. Auto means self. You are collecting the patient own cells and again reinfusing the same stem cells in the body. That is called autologous stem cell transplantation. Okay. The second one is allogenic transplant. In allogenic transplant, you need a donor. The donor can be brother, sister, father, mother, kid, anyone. So if you have 100% donor match, generally the brother, sister, you take the stem cells from the brother or sister, the donor will not lose anything, just 100 to 100 ml of blood. That's it. They are 100% safe. That's not okay. It can be just donated on the, you can say, the platelet, like just I told, the platelet donation machine. Or in some patients, we directly take sometimes the bone marrow in the AOT. But the donor is 100% safe. Nothing happens to the donor. And if it is the half match, only 50% HLA match, that is called haploidentical. Procedure is same, just we before what we do is give immunotherapy, chemotherapy, or the radiation. It differs. The complication differs. But this is the one, autologous and allogenic transplant. Allogenic has got two types. You can say 100% match. 100% match can be either brothers, sisters, or it can be anyone different in the world. My HLA can be matching to someone sitting in the Germany, and if I need that, it can be contacted through a registry. The stem cells will come, not the patient or the donor, and the donor stem cells come. It can be it can be infused to me. So that's the way. And half match, every family member will have 50% match. Everyone will match at least 50% to their father or mother or their brother sisters. So that is the haploidentical. So everything is available in the family. Only thing you have to tell. Now, coming to the autologous transplant, autologous, I said autologous means collecting the patient own stem cells and reinfusing it. So, what are the diseases? Most commonly is the multiple myeloma, relapsed Hodgkin's and non-Hodgkin's lymphoma, neuroblastoma, sometimes relapsed APML, and Ewing sarcoma. The most common is multiple myeloma. So it's a part of treatment regimen when you give chemotherapy, immunotherapy, and in multiple myeloma, you do the transplant so that it just prolongs the life. Okay, so I'll just go on to the some case scenarios. Okay, in multiple myeloma, what exactly happens? So we have a patient, 52-year-old male, pharma by profession, presented in OPD in February 2022, complaints of backache, 2 to 3 months. Evaluation, you can see almost blood tests were normal, except the creatinine was little bit high, uric acid high, hemoglobin little bit less. LFTs, you can see the total protein was high, albumin was low, and the X-ray and CT scan shows some lytic lesions. The PET scan was done, shows L1 compression fracture, for which he was complaining the backache. We did the bone marrow, and now the plasma cells. This is a part of bone marrow. It is malignant. The cancer is something. It's a part of body. Okay, you must understand. Cancer is nothing extra. We are made from two cells, sperm and the ova. They divide before a human body is born. So every cells divide, one remains, other dies. That's how God has made us. But if a cells divide into 2, 2 into 10, 10 to 1000, that is cancer. If it is happening in the skin, it is called skin cancer. If it is happening in the liver, it's called liver cancer. So if the bone marrow, the plasma cells are increasing, they are not dying. So normally is 1 to 2%. Now here the plasma cells was 35%. The bone marrow biopsy had short sheets of plasma cell, the M band. So these are all classifications. Say protein level is high, kappa abnormal protein. M band is normally 0. It was 4.5. So it was finally diagnosed to have multiple myeloma, IgG kappa types, high risk disease because of the mutation analysis we do. And then the patient was treated with chemotherapies into 4 cycles. Post 4 cycles, the protein level was normal. Then we planned for autologous. Why autologous? Just because it will give the prolongation of life. It is not going to cure, but it will prolong life. In my training days, we used to counsel the patient that, okay, once multiple myeloma, your life is around 3 to 5 years. Now, the world has changed. Immunotherapy has come. Transplant remained the same. Now, the lifespan can be as long as 10 to 15 years if properly managed. So that has changed. So as we go much and much better, now the CAR T cell has come, the bispecifics have come. So any patient of myeloma, if now diagnosed and managed over a period of time, only thing is he will require treatment for a prolonged period. He can have normal life, 20, 25 years of life. but it involves the cost. Second case scenario, where say a relapsed non-Hodgkin's lymphoma, you can see the lymph node in the neck. So it was initially diagnosed, 60-year-old, diagnosed in November 2019, diagnosed to have diffuse large B-cell lymphoma, stage 3, treated with six cycles of chemotherapy and immunotherapy regimen, and patient was in remission till October of 23. Now again presented with a lymph node, rebiopsy was done. Again, it was diffuse large B-cell lymphoma. Now what? Whether to do the chemotherapy and leave it, again it will come. So what we did was we gave the 3 cycles of high-dose chemotherapy, salvage regimen, PET scan showed complete metabolic response, and the patient underwent autologous bone marrow transplant. Still, the patient is in remission. If it is in remission for another 3-4 years, patient is cured. Now, autologous stem cell transplant, I gave you 2 scenarios. These are the 2 most common things, 2 common diseases for which we do the transplantation, multiple myeloma and lymphoma. So how do we actually do that? So before transplantation, you must understand the patient should be in remission. The disease should be under control. So you give chemotherapies, make sure the disease has almost negligible. Then we give some injections, that is filgrastim, okay, depending for 4 to 5 days. And the 5th day, we take the patient to the, we admit the patient and do the collection, or we call stem cell harvesting. Same machine. These you can see in the second, that is the patient is being the second one, the patient is sitting on a couch, and you can see stem cell being collected. Okay, the red one, which is these stem cells. So it's not like that is surgical process. You just have to 3 or 4 hours on this machine, and the stem cell is collected. After that, we collect this, what the collected stem cells go to the lab for enumeration. We need specific amount of stem cells. So if the counting is normal, we need around 5 million cells per kg. These stem cells either can be used freshly, it is alive for 3 days. If it has to be used later days, we usually freeze this, cryo-freeze this stem cells. And then again, after giving chemotherapy, that is we call conditioning regimen, these stem cells thawed and reinfused just like a blood transfusion. So you give chemotherapy, conditioning regimen, you kill all the remaining bad cells, cancer cells, and you reintroduce these stem cells again, so to make a new marrow, new immune system, and the patient have a longer period of life. So this is the one, we do the collection of stem cells, we do give the chemotherapy that is different from what he has received initially, the 3 salvage chemotherapy. This is called conditioning regimen. It is different for different patients. It can differ from different disease. And then the third is the stem cell infusion. Now, autologous transplant, bone marrow transplant in relapsed Hodgkin's lymphoma or non-Hodgkin's lymphoma, it is almost 50 to 60% chance of cure. If I treat 100 patients, 60 people will never receive will never have the relapse again in their life. They will be labeled as cured. In multiple myeloma, 40 to 60% of they will have 5-year progression-free survival, almost 40 to 60%. So this is what autologous bone marrow transplant, where their own stem cells. This is the easy one. It can be started here. Only thing what you need, a HEPA filter room. You need a what you say, already you must be having the apheresis machine, and you need a flow cytometer to count the CD34 cells. So this is what you need. That's all. It's easier than giving chemotherapy. Only need a clinical expertise to start the autologous transplant. It is just in the mindset. The tougher one is allogenic transplant. This is really need time, patience, and you must understand not all patients are going to make it. Okay, it can be curative, but at the same time, it's the other way around. If not properly managed, we lose the patient. So I always say, I'll use this phrase again and again. It's a hard pill for someone to swallow, but the cure for death to others. The allogenic transplant, it's tough for the patient, but that's the only way to cure in some diseases. So we'll see what are the indications of allogenic transplant. In the malignant disorders, yes, acute leukemias, AML, ALLs, high-risk ALL, relapsed or fresh case, newly diagnosed cases with the high-risk mutations. We know the chemotherapy is just prolonging life, but for cure, you need bone marrow transplantation. CML, generally curative with one magic drug, imatinib, dasatinib, nilotinib. But in the blast cases, you need chemotherapy followed by transplant. High-risk Hodgkin's, non-Hodgkin's lymphoma who have failed autologous transplant, it can be cured with allogeneic transplant. In non-malignant cases, severe aplastic anemia, we know ATG works in few, but again, it is the transplant which makes the change. Curative. Congenital bone malformation syndromes like Fanconi's anemia, curative. Hemoglobinopathies like thalassemia and sickle cell anemia, again, curative. Inborn error of metabolism, congenital immunodeficiency. You don't have life if you don't do the transplant. Hardly they will see first decade of life. After that, almost every patient dies. So before that, they are too sick or infected. If they go for transplantation, they have a fair good number that they will be cured. So, so how does it differ from autologous transplant? In autologous transplant, you need the patient own stem cells, but here you need a donor. The donor, as I said, can be brother, can be sister. So how exactly? We'll have some slides on the donor. So the test we need is HLA, human leukocyte antigen, and that is the class 1 or class 2. It's class 1 ABC and class 2 HLA DR DQ DP. So this is the test which we need to develop. So you must have an HLA which is on the short arm of chromosome 6. If you have an HLA, it's a unique number set which is present from birth till death. You cannot have a HLA which is something today and it differs after treatment. No. Once you have an HLA set, it is going to remain throughout your life. So I will explain you. Okay, so there is a color combinations. You can say if there is a dad and the mom, you can say different color combinations. The dad has got blue and the red, and the mother has got the green and the orange. Now, what are the possibilities that kids will be having? The son, you can see the child one gene from the father, one gene from the mother. Okay. The second child, again, one gene from the father, one gene from the mother. Third child, fourth child, again. And you can see the fifth child. They're sharing the same haplotypes. So child 1 and child 5 are matching to each other. So the child 5 can donate to child 1 or child 1 can donate to child 5. Okay, these are the haplotypes. Now, it doesn't mean a family should have 5 children. It's the nature's call. You can have 5 person in the family and nobody is matching. Everybody is haplo match. Or you can have 2 children in the family, but they are haplo match. Full match, sorry. Okay. So you have to check that. And it is always that. So once you check the HLA, and always remember you have only got 30-40% chance that the patient will have 100% match in the donor, in the family. So we need alternative treatments. So even if you have a leukemia, you have given chemotherapies and you have no donors, so what to do? So you can have either go for haploidentical again. So you can see every one child is at least 50% matching to the child one. Okay, so they're haplo match. Now, or you can use the cord stem cells, that is called umbilical cord stem cell transplant, but more common these days is 50% match, almost 90%, either they will be matched to the father, mother, or the siblings. Now, this is the typical report just for presentation. This is the HLA report. You can see these are the numbers which will be there. Okay, the patient on the A locus, the B locus, C locus, and the DRB. Okay, so this is the one which we need. So these numbers, when you have the patient, you have again matching to the other kids or the parents. If they are matching, you match the numbers and you can tell, okay, this is matching to the donor and this child is going to donate the stem cells. So this is the type of result. This is the lab you must be having, or you can send the samples so to get this type of results. So sometimes we get the query HLA and they say we have got HLA B27, we have got HLAs for different disease, but not this HLA what you are asking for, HLA A, B, C, DP, DQ, DR. So once you have the matching, you can then further decide who the donor will be, who has to come to along with the patient to donate the stem cells. Now, if there is no family donor, but still there are different registries throughout the world, NMDP, DKMS, Anthony Nolan, Datri in India, Gene-Bandhu, MDRA, where we can be the donor. Suppose I want to donate my blood, it's easy. Go to the blood bank, donate your blood, go home. Every 3-4 months you can donate. But if you want to donate the stem cells, these are the registries. You can enroll yourself and just wait for their call. maybe you are lucky, you can donate. So donation again, if my HLA is matching to anybody in the world, they will contact me, they will do the retesting, they will collect my stem cells, and it can be taken to any part of the world where the patient is. I don't need to go. Just the stem cells, just the bag goes. Okay, and it can be done. So it's a very efficient system, but everything has got a cost. Now, again, the same child, I'm saying the same set, it's a haploidentical, and you will have 90 to 100% chance that every patient can have the haplo identical. So the stem cells initially, you can either you collect from the patient from the bone marrow. We have to pose the patient in the OT and manually collect as you see on the left side of the that we are collecting the bone marrow. You are actually in the OT, you have made the patient prone, given anesthesia, and you are actually puncturing the bone and taking the bone marrow. At least 100 to 100 ml of blood we are taking. That is actually collecting the stem cells from the bone marrow. It is being used still in thalassemia if the patient is having thalassemia, or you are having aplastic anemia where you don't need GVHD. So this is the way. So we are collecting the stem cells. Also, this is the another way which I told you. Give the Plerixafor to the patient. On the 5th day, patient just lies down. It's being connected to the machine, and you can see on the top corner the stem cells are being collected in the bag. And once it's collected, you just calculate the CD34 cells. These are the stem cells enumeration, and you need 5 to minimum 5 million cells per kg of the donor. And if you have collected, otherwise you have to repeat the process the next day. And once you have it, you can reinforce. The same time the patient is being admitted, is being given conditioning therapy. It's a set of chemotherapy and immunotherapy, and the same time the donor is receiving the Prelexafor, and we coincide with that. The one day before the infusion date, we have the collection plan. So what we do in the allogenic transplant, we prepare the patient to receive this stem cells. So if I infuse the stem cells just like that, the body is going to reject. Okay, the patient's own immune system is active and it's going to reject. So make him more compatible. We immunosuppress the patient's immunity by giving the chemotherapy or immunotherapy, or sometimes few doses of radiation. We remove the lymphocytes from the, so that the patient will accept any stem cells coming into it, and they will not going to reject that. And over a period of time, they come in. It's the both live to coexist, the patient and the donor cells. So what are the conditioning regimen? This is a group of medicines which we use commonly: busulfan, TBI, total body radiation, melphalan, cyclophosphamide, fludarabine, ATG. And this is depending on what exactly the patient condition is, whether it's the first time, second time, it's a relapsed. You can, depending your dose intensity, whether you want to give higher doses of chemotherapy or you give minimum doses. Okay, you more of a immunosuppression or more of a myeloablation. So these are different type of conditioning regimen. Whether you myeloablate, you fully ablate it, you give reduced intensity, less amount of chemotherapy, or non-myeloablative, depending. Like aplastic anemia, we more commonly use is non-myeloablative. Myeloablative, when the patient has relapsed again and again, we know fully we have to remove the whatever the marrow and the more competent immune cells of the patient, original immune cells, we use myeloablative conditioning regimen. The stem cell infusion, so it's just like the blood transfusion. Just you connect the stem cells to the patient's vein, like from the catheter, it goes inside. The stem cell expresses this CXCR4. The stromal cells in the marrow spaces have excess of SDF1. The stem cells which move to the marrow places retain there under SDF gradient. That is called homing of the stem cell. It just takes 1 to 2 hours. Many other receptors ligands are involved, but this is the main, just to be on the engraftment. So what happens is when you give the chemotherapy for 1 week, the patient hemoglobin drops, that WBC will go to 100, 200, the platelets count will be in the range of 5,000, 10,000. So during that time, the patient is severely immunocompromised. The patient has to be kept in HEPA filter rooms. Very limited access. One patient, the patient attendant is there, not allowed to go outside. We also change ourselves, go inside, see patient once, that's or twice a day, and see anything going wrong. Be it the patient can have tachycardia, it's a sign of sepsis. Patient can have loose stools, it's a sign of sepsis. During this time, the patient is like on antibiotics, antifungals, depending. It doesn't mean that patient is very sick. Patient can be just sitting, eating their normal meals. But if you have any infections in the body, any sign of infection, it's not may not be fever. Fever, it can be just, I say, tachycardia. Just patient had tachycardia means patient doesn't have immune cells. We have killed all the immune cells to express the fever. So that has to be clear. That's the clinical set you need to understand. So after that, it takes generally 10 days to 14 days the new stem cells to grow. And you can see from count 0, WBC count 0, it slowly goes to 0, 0.1, 0.2, 300, 400,000, and it's an exponential rise. So if you have the neutrophil count more than 500 per microliter for 3 days, or platelet count more than 20,000 for 7 days unsupported, that is called engraftment. That means the stem cells gone in and the stem cells started working. And when we do it's called chimeriza test, we check that how many the percentage of stem cells of the donor is working in the uh, uh, patient. That is called chimerism. Again, GVHD prophylaxis, because we are playing with the immunity. If the donor immune cells are too strong, it is going to affect the patient. It too strong means when we are hitting it, patient can have redness of the skin, that is, or can have loose motion, can have liver affected. These are the three main organs, but actually any organ can be affected. It's the severe form of autoimmune disease. So to prevent this, we are using some immunosuppression over a period of 5 months, 6 months to maximum a year, and then generally we taper. So that's one of the difference between liver transplant and kidney transplant. Patients who require lifelong immunosuppression, we generally stop in 6 months to 1 year, depending on the condition. So GVHD prophylaxis, and if the GVHD still occurs, we treat the GVHD. We have to give more immunosuppression over a period of time, and if not monitored, that can also kill the patient if it is not properly managed. So it's not like that one day process. Even after the patient is discharged, we ask the patient to stay around the hospital for 2 to 3 months. Generally, first 100 days, if the patient are okay, then we send back to their native place with the list of. So once the patient come back, they can contact their own doctors, and if any problem, we are available on the WhatsApp, on the mail, and we can help the patients locally. So what is as I told, acute GVHD or chronic GVHD? Its problem, if not properly managed, the patient can die of GVHD. But once the patient has developed GVHD, you are giving more immunosuppression. The more you are suppressing the immunity, more chances of infection. So you can have plethora of infections. You name it, we have seen it. You can have viral infection, you can have fungal infection, you have multi-resistant bacterial infections. So it's a very long, tedious job. You have to manage the patient's cancer, you have to manage the patient's immunity and the infections. Long-term sequelae, yes, patient can have organ dysfunction, endocrine dysfunctions, and secondary malignancies. Not that every patient will have. At least 5-10% patients are those in long-term 15 to 20 years follow-up. We do see these problems. So coming to the case scenario, like acute leukemia, 36-year-old female came to her OPD on March 2023, fever since 2 weeks, fatigue since 2 months. You had that hemoglobin 5.8, WBC count for 39,000, blast was 54%, platelet 24,000. Bad shape, we did a marrow, 76% blast. Flow cytometer suggestive of acute myeloid leukemia, cytogenetics was high risk. NGS had KRAS and the FLT3 mutation, and the final diagnosis was acute myeloid leukemia, and it was high risk type of AML. Presented with gum hypertrophy, some skin particle rashes is a common thing. So what we did, we gave the induction chemotherapy with fludarabine, cytarabine, venetoclax, and after 1 month, the patient was in remission. Patient was haplo-identical match with the brother. The DSA class 1, class 2 was negative. That's the requirement for haplo transplant. We did the BMT. Conditioning regimen was used fludarabine, melphalan TBI with post-transplant cyclophosphamide and tacrolimus. This is the way it goes. I will just giving you how it went. So we have to say day -7, 6, we have to plan our chemotherapies during that time. From day -8. So it can differ. Just I'm giving an example. And day 0 is the day of infusion. So during that time, the donor is also being started the suffer from day -5, he receives for 4 days, and day -1, the stem cell is being collected, and day 0, the infusion happens. And after that, day 30 till he's with us, you can say, and after that, he gets discharged to be followed up in the OPD. So this is like all coordination. It's being protocol is being made, explain to the staff, explain to the patient. One of the copies is with the patient. We say, okay, this is the thing, and if successful, patient can get cured from the life. So this is the one you can see. It's not like that. I said this is the patient from Cambodia who was having acute leukemia. The patient was treated locally. They came for transplant, and you can see the husband's standing there, just clean clothes. It was in WBC 0, platelet count over 5,000. Patient was very well. It's not eating normally, but he cannot go outside. The patient cannot move out to the HEPA filter room, can be there. Another patient brought their guitar, the patient, and he was singing to us. Whenever we used to go, he used to sing us a song. So patient is doing well. He's doing okay. These are few patients. We can say this. You can see the transplant room, and the patient used to sing a song for us. You can see.
But we go here.
Yeah, I said sorry. It's the IT. I'm not, but this is the one of the. So this is the one we can say the few last slides. Indian Stem Cell Registry. We are doing almost 15,000. This is a little bit older slide. Almost 15,000 transplant. You can see in autologous transplant, myeloma is one of the main. The next two common is the Hodgkin's and the non-Hodgkin's lymphoma. In allogeneic transplant, you can see acute myeloid leukemia, thalassemia constitute of 50% of the cases. The rest, aplastic anemia, ALL, relapse, ALL, CML are the one. So this is the way we deal with this, and this is the international US registry. You can see the green one is the autologous transplant, and the blue one is the allogenic transplants happening over a period of time. It's increasing. You can see the initial spike was when the breast cancer was also being treated with autologous transplant stage 4. That was a spike, and then it had negative results. It was stopped. And then lower bar diagram, you can see the haploid identical transplants increasing over a period of time, mud transplant increasing over a period of time. So this is the one just to show it's almost, and this is by most commonly you can say autologous transplant, multiple myeloma most common, and then the AML, allogenic transplant, non-Hodgkin's. This is the frequency. What the other thing is there, and you can see this is the Kaplan-Meier graph. If you are doing the transplant for AML early, CR1 is the first time when the patient is diagnosed, you have got almost 60% chance of cure. But if the patient has relapsed, that success rate reduced to 30%. So once you have been diagnosed with cancer, and if it are indicated, do it the first time. If you're doing the second time, once the patient has relapsed, you already know that's very less chance of cure. Now, last slide is CAR T cell therapy. Now, what happens if this also fails? Now, this is a typical success story, very new thing, very exciting. We have done 15 cases of CAR T cell therapy. So, two indications till now. This is B, acute lymphoblastic leukemia, and relapsed B, non-Hodgkin's lymphoma. These are the two indications. We have done trials for multiple myeloma, but what approval we have got it. So how we do it? If I am the patient of relapsed B, acute lymphoblastic leukemia, and I have failed allogenic transplants, what next? Or I have not yet gone the transplant, but I am not fit for the transplant. So my T cells will be collected just like from the apheresis machine. The T cells will go to the lab. It will be mixed with a virus vector, and they will such that a new medicine is made. That is called chimeric antigen T cell receptor. And when it generally takes 2 to 3 weeks, it's in the lab. And when it's shipped back to us, we have to just reinfuse it. That CAR T cell can cure 40% of the patient in long term. So that's the newer thing which we have done. It's a costly, it's almost, you can say $400,000 in the US. We are doing in $50,000 to $60,000. So that's the scale. But yes, it's a newer thing. And apart from bone marrow transplant, we are doing CAR T cell therapy, but in only two specific at present. Maybe in the coming years, we will get the approval for multiple myeloma. So again, to conclude, Allogenic transplant, it's the hard pill for someone to swallow, but the cure for death to others. With this, I will end my talk. Thank you.
We'll encourage questions from the floor. Let's be interactive and let's learn a lot from this offering.
Thank you, Doctor. Indeed, it was a very rich experience to acknowledge all of us with the possible treatments that we have actually in India. So I would like our audience to participate in this event by asking your questions and enrich our knowledge more. So please feel free. Any questions in our audience, please?
Yeah, thank you, Dr. Ahmed. I think it's very clear and very understandable. My question is regarding the siblings. Whenever you were showing the five potential children, I think between child two and child three, there was absolutely no HLA matching at all. So that could potentially also happen that you have siblings without any haploidentical status at all. So if ever that is the case, or somebody does not have any siblings, and what are the other factors that get into consideration whenever you're navigating your decision making with respect to their matching? What are the non-HLA factors, like maybe age or CMV status, or how much weight do you ascribe to each of these, and how do you make a decision based on that? Thank you.
Sure. Thank you. So what I'm understand is if the patient is not even haplomatch, then what's his chances? What we are going to do? So if the family doesn't have haplomatch, uh, we can check with the parent if they should have at least. So one gene is coming from the father, one gene is coming for the mother. So the parents become, suppose parents are not available, they are separated or they don't in a medical condition, then what we can do is the checking in the international registries, which I told. So they have to get the 100%, or we can also take the 50%, not that successful. 100% mismatched donor is better. So that is, you can take, as I tell, I can be a potential stem cell donor for anyone who is matching to me. So we prefer that. So the order of transplant is 100% match family donor, 100% followed by 100% family unmatched donor, anyone, followed by haploidentical. So we live in a big world. Okay, so you don't need have select China. They have got one till now. They had one kit policy. So there will be no allogenic transplantation. So their data is all about haploidentical transplant or matched unrelated donors. So the lot of good data from China about haploidentical. They have good things. So or you can have someone in the family who doesn't have the even haplomatch. They are not fit for haploid. So then you have to go for again international registry. So it works. It's not only that 100% family donors there. You other two options. But there are also 5 to 10% of the patients who doesn't have anything. So in that case, we have to just content with the chemotherapy. Then transplantation cannot. So minimum we need is 50% matched donor, not 40%. We cannot do 50, 60, 70 will do the same protocol. So one protocol is for 100% matched donor, another is anything less than that. The protocol too differs. Sure.
Help. Hello, Doctor. Thank you again for the presentation, and I'm happy you're enjoying Mauritius. I just wanted to know in India, what are your exclusion factors for your protocols? Are they different from a European protocol, for example?
Yeah, so every country has got a learning curve. So days were there in around 2000, and we were seeing more for the infective deaths than with the transplant related, you can say, the disease related deaths. So over a period of time, we are able to modify our doses. We just cannot cut copy paste from the Europeans or the Americans. They have got their own problems. Like I'll say, in India, we see more of a gram-negative sepsis than gram-positive sepsis. For the Western world, gram-positive sepsis is a problem. For us, it's not a problem. More problem is the gram-negative sepsis. Again, the Western world doesn't have CMV activation. In India, almost 99% of the uh, patients who come, they are already CMV activated. So we are not worried for the CMV. Okay, so we don't require those protocols what they are following. So it has been over with that learning curve that, okay, what is our priority? So some difference we have to do. It cannot be, again, the PKPD of the Europeans are different for the Indian population. Again, we are saying we are not the Asians, we are the Indian population. Asia is a big thing. Chinese, Japanese, their PKPD is different from what we have. So the tolerance to a drug, tolerance to TBI is totally different for. So we can just take those as a blueprint, but we have to modify. So even when it is being done on the international patient, we keep in account what the patient previous tolerance to the chemotherapy was, what was the infection profile. If we get this information from the, it helps us. So it has to be tailor made for every patient. It cannot be just one blanket.
Thank you. Thank you, doctor. Any more questions from the audience, please?
Good evening, sir. I'm Dr. Bandhu. I'm a radiation oncologist in Mauritius. In your current practice, doc, how do you actually choose between TBI and chemotherapy for your conditioning process? Thank you.
Okay, so most of the 100% matched donor will not require TBI. We are moving away from the TBI. And the TBI, what we are using is only for the lymphoid malignancies, where we need more of the marrow lymphocyte ablation. So lymphoid malignancies like ALL still uses around 200 to 1200 grays of TBI. And also from the TBI, we have moved to TMLI, total marrow lympho irradiation. So that is the step. So the toxicity can be reduced. In the myeloid, where we need the haploid indical, which we require more of immunosuppression, some 200 to 400 centigrades, that's enough for us. Otherwise, we don't need TBI. So the first cases where the immunosuppressions were not that strong, the world was learning, the TBI process was more common. The TBI-based conditioning regimen was more common, but we saw the side effects of TBI, secondary malignancies, endocrine. So world moved away from that, but still used in specific subsets and at a lesser doses. Sure.
Yes, good evening, Dr. Ahmed. Thank you very much for this enriching presentation. My name is Dr. Gouria. I've heard about, I've learned that you said about immunosuppression for BMT. In this case, it takes like after 1 year, the patient is off immunosuppression. But it's not only always the case in terms of liver transplant and renal transplant. So I've been to a talk a couple of weeks back where they were mentioning about transferring stem cell of the donor while the patient receives a kidney or part of the liver as transplant, and the possibility of eliminating immunosuppression in the long term. I'd like to know your views and opinion on it, and what is Max Hospital doing in this kind of studies and techniques. Thank you.
So this becomes very specific. You have to work in coordination if it is done for the kidney transplant and the immunosuppression. So we have to fix individual case. These are, and again, remember, these are very, very individualized cases. Not all kidney transplant will patient has to go for it. So the long-term process of the kidney transplant patient is very minimal immunosuppressions, 10 years, 15 years, till the graft works. And in any reason, if the patient has developed something else, like post-transplant lymphoproliferative disorders, where you need to decrease the immunosuppression for treating the PTLDs, or you require chemotherapies, which is again immunosuppressive, it needs to be done, then we do it. And it's not like a uniform that, okay, stem cells has been taken in the liver transplant or the kidney transplant for the donor. It's not like a routine thing for them. It's very individualized. So 1 or 2 cases you can be, and again, a lot of factors come into play. What is the current situation? If the donor is available, if the donor is having any other problem, if the infective. So this is very, you can say, not a good place to discuss about those things. It's individualized. It has to be multidisciplinary board meetings where you have to discuss each and every point before you do that. Because again, once you put the stem cells inside from the same, it will have its pros and cons. So needs individual care.
Thank you, doctor. Any more questions, please? Somebody from the audience for another question with the doctor?
From the nurses, maybe.
Nobody?
Okay.
Okay, so thank you so much, Dr. Rayaz Ahmed, for this lovely presentation and the exchange of experience in the medical field. And as from here, so it's Dr. Nilambo who is going to introduce our second speaker, which is Dr. Kulbhushan Singh Dagar. Thank you so much.
Thank you very much. So our next speaker today will be Dr. Kulbhushan Singh Dagar. He is a chairman and head of department of the neonatal and congenital heart surgery of Max Super Specialty Hospital. He has been working in this field over 30 years, and his area of expertise is complex and challenging cases in congenital heart disease, and he has been leveraging innovative techniques and leading edge technologies for the care of children with heart defect in India and overseas. He has also been awarded the first prize in the management of cardiopulmonary bypass in infant with sickle cell disease, which is something which I had never encountered before. So it will be a great pleasure to meet such a experienced doctor, and I open the floor to him. Thank you.
So thank you so much. Good evening, ladies and gentlemen. I'm Dr. Kulbhushan Singh Dagar, and I bring you greetings from Max Healthcare. I work here at Saket. Can somebody please dim the lights? In the room. Yeah. So this is not my first visit. I've been to Mauritius before, and thank you very much for the warmth and the hospitality. It's really a lovely country that you have. So today we will be looking at how the practice of pediatric cardiothoracic surgery has evolved over the years, and it all started in the late 1950s. And it was basically in the 1960s where we discovered the heart-lung machine and how to do artificial perfusion, that the thing really took off and exploded. And then over the years, science has sort of added. So there's always been an evolution of the way we sort of looked at perfusion. Robotics is now stepping in. There's going to be a lot of thing in bioengineering. You all would have heard of artificial hearts and mechanical support. That is more in context of the adult program and less so for the pediatrics. But ECMOs and short-term runs are sort of becoming more commonplace in pediatrics also. So all of this has got to do with the science, and it is continuing to evolve. Now, the challenge that comes into pediatrics is that you have a very wide age range. So you're treating patients from 0 day of life to anybody with a congenital heart defect who may be 60, 65. The oldest that I've operated is a 74-year-old gentleman. Plus also the wide spectrum of the disease entity. So you can have a hole, you can have malpositioned blood vessels, You can have the heart not formed, your valves may not function well, the heart may not function well as a pump. So, how do you now integrate the science which exists to this complexity and then still be able to deliver things like this? So you're operating on a 2.8 kilo child with an obstructed TAPVC. So those are the pulmonary veins which are coming back abnormally connected. They're occluded here. Absolutely critical. They don't survive for more than the first few months of life unless they're intervened on. So how do you amalgamate the two? And that is where the art comes in. So the topic for today is the art and the science. And I hope over the next 30 odd minutes, I would be able to share our experiences at Max. And you are sort of better aware of what are the possibilities that exist for a child who has a congenital heart defect in today's day and age. So to start off with, the journey would begin with a strong index of suspicion. So the moment a child is born, you need to suspect that it's not normal and there may be a possibility of a congenital heart defect. And I think the commonest is which most people should be able to pick up is cyanosis, or which is blueness. And it should be mandatory in today's day and age for every child to have an oximetry run. And then one could take it forward from there. So cyanosis is never to be ignored. A fast breathing or difficulty in feeding, heart murmurs sort of being evaluated for other things and being picked up incidentally. All of these are very high indices of suspicion that there could be an underlying cardiac defect. And all of these children should then be moved on to a specialist. Unfortunately, in most countries in Southeast Asia and in Africa, it is an adult cardiologist who would be looking after the children. We at Max have sort of moved away from it. So we have got a standalone pediatric cardiology and a cardiac program. My team will not look after any adult unless he's got a congenital heart defect. So once the suspicion is there, like I said, oximetry is very common and should be done for all. Once you have a suspicion, then the next thing is to how do you sort of narrow it down and how do you establish a diagnosis? So there's a whole gamut of things which could be done. X-ray test is mandatory and can give you a lot of information. But I think the mainstay in today's environment is going to be an echocardiogram, which could be either fetal or it could be after birth. You have the 3Ds and you have the 4Ds. So basically, they're just trying to evolve and build on things. But a normal 2D echocardiography in the right kind of hands does wonders. And in nearly about 75-80%, one should be able to go ahead for surgery also, entirely based on echocardiography. What has really sort of changed is like heart catheterization used to be the mainstay till about decade and a half back. Cardiac MRI is now taking over. It's the new kid on the block, and I can see the doc getting really excited about it. And you all are very lucky that you soon have MRI available in Mauritius. So there are a lot of advantages which sort of exist. There's no radiation. You can get viability studies. There's better tissue differentiation. Myocardial tagging is always possible. What is, I think, most important is that you're able to incorporate the physiology along with the anatomy. And also now, very strong scoring systems and prognosticating factors have come up for cardiac MRI. Slowly, we're trying to move away from cardiac catheterization unless there are very specific indications, and sort of we can look at that. The only problem with the MRI is got a very steep learning curve for pediatric MRI. You really need to have a team which is good, which is dedicated and focused. So one guy fix it all, not happening. You need somebody who's really focused on doing pediatric MRI. The second thing is that children not very compliant. You would need some sort of sedation. So that adds to the complexity of the procedure. You can't do it as a daycare. You need to admit them. and you need a dedicated anesthesia team to be looking after that. So other than these two challenges, it's a phenomenal modality. Those are just certain sort of images which tell you the amazing anatomic delineation that can happen. That's an IVC which is opening into the LA, which is clearly abnormal. You have a pseudocoarctation which is there. You can see a VSD, aortic override. It's a DORV. So amazing anatomic visualization. What I'm sort of like coming to and what I mentioned was that there's an overlap. So you have an abnormal pulmonary vein which is draining into the right atrium. So big deal. Do you really need to intervene? Do you really need to intervene? The answer to that is a no, unless there are hemodynamic considerations which are sort of driving excess amount of blood. And how do you get to know that? So initially we were having to catheterize them. Echocardiography would not, they would give you very subtle signs like dilatation of the right side of the heart. And possibly if you had a regurgitation, you could look at the RVSPs and the EA diastolics. But MRI is definitive. It's giving you a QPQS, standardized signs. More than 2:1, you need to go in and operate on this people. What has sort of really changed is things like how do you manage pericarditis in today's environment. So initially, you had somebody diagnosed with the pericarditis for whatever reason. So you put them on anti-inflammatory medication. You started colchicine, probably added steroids, and everybody would be using some combination. And so there was no logic to the way they were doing. MRI sort of transformed that. The T1 scans give you actually give you the degree of thickness. You can look at the the amount of sort of inflammation which is there, and this can then be done sequentially. So if you put a patient on a certain set of medication, it will be able to tell you as to what the evolution is. And if there is no inflammation at the end of, let's say, 3 to 6 months, you could actually take off the medication. You don't have to get into rigid protocols saying that, okay, you need to give it for 1 year, etc., etc. And if it is persisting, nowadays you have these newer IL-1 blockers, things like rilanacept, etc. So you can take off the steroids and add the rilanacept at an earlier stage. So it's definitive, it's targeted, and it is safer. Viability, very important. So this is a case with an L-kappa, which is an anomalous origin of the coronary arteries coming from the pulmonary artery. What that does is that you do not get oxygenated blood going to the heart. The muscle dies. But the children will come to you late. I mean, as is usual in Southeast Asia, this thing should be picked up in the first week of life and operated. But it's very common to have them coming in at 3 months, 6 months. They will always have a dilated heart with ventricular dysfunction. Now, the challenge for the surgeon used to be when I started training was that even if I sort of relocate the coronary to the aorta, is this function going to come back? Is the mitral valve, which is leaking, going to disappear? And you could never. So those are the questions which were asked by the parents. We never had an answer. We say, okay, well, let's go ahead, do it, and then time will tell. Not anymore. So if like this is a delayed reperfusion scan, which is showing areas of scarring, this is never going to come back. So right at the time of counseling of the patient, you can tell the parents that one can try. It's unlikely that unless the other parts of the heart take over, the congestive heart failure may not disappear, the MR may not disappear. Now, why this is important is for the financial implications. Some families would not want to proceed. So there is a scientific endpoint, but it's also an art now. The other science things which have sort of really changed is we looked at the diagnostics. Fetal echocardiography is now becoming very, very good. And nearly 95% you'll have a diagnosis by the time you're sort of 20, 25 weeks of life. Why this has sort of transformed things is that these deliveries can now happen in a tertiary care hospital, and the child can immediately be assessed and then moved to the operating suite if it is needed. Surgical skill sets have increased and improved. Cardiopulmonary bypass technology, we're not there yet. We've become much, much better. I would say a zillion times better, but still there is a lot of things which need to happen. We're working on it, and hopefully next probably decade and a half, we should have safer bypass techniques. Landmark changes which have sort of happened in the post-operative management sphere. Forget the medicines for the heart. What is now better understood is optimizing pain management. Till about 2 or 3 decades back, everybody was giving PCM, and then some would come and give a steroid and some opioids, and we just leave the child. And then Dr. Anand in the United States of America started looking at the neurological development of these children, and they found that children who were going through pain actually had poorer neurological development and indices down the road. Pain management has now become mainstay. We would not allow, so they have fantastic scales which would sort of quantify and give specific endpoints as to what is the pain that the child is going through. And we are very, very aggressive in the way we manage pain for these children. Now, once you have a diagnosis, you have all the tools and the wherewithal to do. What are the questions that you need to answer? So I think the first question that needs to be answered is what is the best time? So over the years, and there used to be dictum that the child should be 10 months old, it should be 10 kilos, it should be blah, 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 and all that. Now, all that has changed. What is the best time to intervene is dictated by the underlying pathology. So if it's, let's say, a simple lesion like an ASD, which is a hole in the upper part of the heart, you can wait them through. 2 years, 3 years is good enough. If it's a VSD, it's pretty much standardized that by 3 months, the child should be operated. So if I were to give you a ballpark number to carry home, most children should have had some sort of an intervention before they reach 6 months of age. Right? And then you can fine tune it depending on what are the underlying pathology. Some children may need to come off for surgery at day 0, but by and large, by 6 months, they should have been operated on. What about comorbidities? We'll sort of just look at them very shortly. So, like I said, it's the optimal surgical window is not chronological age. It's never going to be a fix that, okay, I'll do it at 8 months and 9 months. It is dictated by the underlying anatomy. An arterial switch needs to be operated within the first 2 weeks. Be it 2 kilos, be it 1.6 kilos, it's immaterial, doesn't matter. If you're not operating by 2, maximum 3 weeks, you've missed the bus. There are ramifications for sort of operating late. They have coagulation, they have arrhythmias, the myocardium has taken a beating because of the abnormalities, your ventricular dysfunction. So all in all, you gain nothing by waiting. Now look at the comorbidities. So most of the children who sort of come to us are coming late because of congestive failure. They're not able to feed, they're not stacking a weight. This used to be, it's still debated, by the way. Even in India, we sort of, every conference we're debating that is cardiac cachexia really contributing towards the outcomes. What we're looking at is mortalities. Let me be very categoric and dogmatic about it. Doesn't change. So whether you operate on an underweight child, you operate on a cachexic child, the end point, which is survival, is not very different between the two. But what is different is the nightmare that you have to go through in the post-operative period. And I would say the answer to that is yes. So if you have the time, you please try and build up the protein energy reserves for these children, stabilize them, and then take them off for surgery. It's so much easier. You can sort of avoid all these complications in the post-operative period. And as they say, a picture is worth 1,000 words. Same. VSD, VSD. Nice, plump kid, happy, extubated 6 hours. Third day is playing around. And the same kid is struggling. So this child stayed us actually for 1 month before we were able to send him home, both are VSTs. So please try and spend some time in trying to build up the protein energy reserves for these children. It's very easy to do it. People shy away, the pediatricians shy away. They just push the kid, okay, VST, go for surgery, go for surgery, go for surgery. It doesn't work that way. I wish they would be sort of more aggressive in putting nasogastric tubes. Mothers are able to feed them. It's got nothing to do with the level of education. We have sort of mothers, parents coming in from village backgrounds, absolutely illiterate. It just takes them 48 hours to learn and become confident, and they do a fantastic job. The pediatricians can help them, and it really transforms the postoperative period. Again, like I said, late presenting, they were waiting. Somebody told them your hole's going to get closed, you wait for 10 years, you put on weight, and everything will be hunky dory. No. He was on mass CPAP for 12 days. Discharge took 6 weeks. In today's environment, tetralogy comes to you in time. You should be home within 7 to 8 days. So now I'll just take up a few examples as to how things have changed. We'll do the common ones, we'll do the complex ones, and you can ask me to stop wherever you want. I can keep going the whole night. Wherever you sort of want to take a walk or something, just let me know and we'll sort of truncate it there. So it's pretty standardized. Science says that surgical closure should happen by 3 months and all sorts of things. But what is the reality? The reality is that 60% of the children in Southeast Asia and Africa are going to come to you when they're 2 years, 3 years, 4 years. I've even seen children 16 years, 17 years with open VSTs. And this is quite common. In yellow is the lung artery pressure. So they are suprasystemic. They're higher than the aortic. How many of you would set this up for surgery? Any cardiologists here? No. So the dictum is that they never come up for surgery. I'm not saying that every person who has a suprasystemic PA pressure is eligible for a surgical correction. We look at a certain number of parameters. This is one condition where you would always want to catheterize them because you're looking at reactivity with nitric oxide. They've already been on sildenafil and busulfan for quite some period of time. If they're meeting the parameters, and basically if the diastolic pressures are falling and the PVRs are coming down, you can offer them a surgical correction, but with a caveat that this may continue to increase in the postoperative. So 30%, it will be unrelenting, and the PA pressures would continue to rise even after closure of the VSTs. So how do you go about doing that? There are certain techniques. You can make flap valves. This is the right side, this is the left. So if the PA pressures become high, the blood can go across the hole, and once they come down, then the flap closes off. There are certain perfusion techniques like the antegrade perfusion, which we presented at the Southeast Asian conference, and we actually got an award for that. So during the bypass, you're perfusing the pulmonary bed. What that does is that it sort of stabilizes the endothelium and makes them less reactive in the postoperative period. Subsystemic, saturation is 100%. This child did well and went home. Multiple VSTs, dogmatic teaching, you ban them. Let the VSTs close and then you deal with the other one. So not anymore. So there are multiple VSTs here, big ones. There are various ways of doing it. There's a technique which is known as endothelization. You are actually not trying to close all the apical VSTs, the main one, the perimembranous ones, the muscular ones, that you close them off with a Dacron patch. The rest of them, you're just bringing the endothelial bands, the muscle bands together. The intent is not to close it. The intent is to establish resistance in the apical part of the heart. And then over 3 months, 6 months, they sort of generally close off on their own. So you can do it with a band. Hybrid, so that's one here, then multiple here. Always difficult to close the apical VST surgically, so that you can close it with a device. Now, this can either be done preoperatively or it can be done on the operating table. And then surgically, you go and close this off. So this was peroperatively. You go on across the free ventricular wall and then you can see the device being sort of placed there. Congenital MR with a VSD. Again, the teaching used to be that you keep them on medication, let the child grow, and then so on and so forth. We have sort of now moved towards doing a single stage correction for them. And this is one of the cases where we have sort of repaired the valve. There's no leakage, just that very small whiff which is there. So it is possible to repair these valves with the VSD at a single stage. They do so much better. Previously, when we used to just close the VSD and leave the MR and get them on medication, ICU stays used to be long and they were really struggling in the post-op even after going home. So this has kind of been transformative. The other common entity is tetralogy. We tend to follow this algorithm. So unless it's a neonate, we'll with other comorbidities like a cerebral bleed or a sepsis or very, very diminutive pulmonary arteries, we would push them towards a complete repair. Definitely after 6 months is going to be a complete repair. So the challenge lies here, the neonates and the 3 to 6 months. Now the challenge with the shunt is that it's sort of very, very difficult to control the amount of blood flowing through the lungs and through the systemic circulation. And to put things into perspective, there is something which is known as an STS data, which looks at the complexity. So a decade and a half back, BT shunts used to be STS1, which was the lower end. Today, STS data is locking it into stage 4. So despite all the advances in medical management, etc., they still have a mortality of close to 16 to 35%, depending on what center you're sort of looking at. So not a great idea to be doing a shunt, but you're still pushed into doing it. So what has changed is that you started doing a Seno shunt, which you take from the ventricle to this thing. What we personally started doing is that what is known as a Brox. Now, this is the worst end of the spectrum. You have pulmonary artery. So this is an 8-year-old child, saturating 50, 60%. The pulmonary artery, that's the LPA, that's the RPA. This is just 3 to 4 millimeters across. Even if you do a shunt in this 3 millimeter kid, the pulmonary artery, sorry, not the child, the shunt is going to block off. And then there'll be multiple sort of redo surgeries, etc. So what we've sort of shifted towards is what is known as a Brox. So in a Brox, the VST has been closed off and you leave a residual hole. So like if it's a 12 millimeter VST, you reduce it down to 5 or 6 millimeter. That sort of decompresses the right ventricle. And then you open up the RVOT. So that was the case of pulmonary atresia. The pulmonary artery was not connected to the heart at all. So you reconnected the pulmonary artery to the heart and you open it up. And if you can see here, this is the VST here. And that's the reconnected pulmonary artery to the heart. You leave it a little obstructive, otherwise there will be too much of flooding into the lungs. This is showing you that after the Brox, this is the pulmonary arteries, that's an epicardial echo. Now you have good blood going into both the lung arteries. So immediately after the surgery, you'll have an increment of at least 1 or 2 millimeters because previously they were underperfused. Now that the blood starts going, the pulmonary artery will suddenly jump. So this thing went from a 3 millimeters to a 5 millimeters on both sides. And then subsequently, over the next couple of months, become better. The saturations, which are 50 to 60%, are now close to 95%. It takes some amount of fine tuning. You might have to go back in the post-operative period to either reduce the size of the VSD or tighten the outflow from the RV. We have been very happy with this modification. We are sort of practically moving away from doing BT shunts. The only indication now for a BT shunt is you can't put a child on bypass for either a bleed or a sepsis. These cases were not allowed, so the apex is somewhere here. This is a smallish RV. And as everybody knows, you need two balanced ventricles. Most people would put them on a single ventricle pathway. And that's a coring which has been done. So you cut away the muscle from the apex to build space and give diastolic volume to the heart. And you're able to achieve a single stage anatomic biventricular connection in these cases. Valves will always be a challenge. Uh, they can be congenital, they can be secondary to infection, rheumatic fevers, so on and so forth. All of us understand that if the leakage has to be got down to zero, the only way to do that is to change the valve. Now, the challenges arise is that small sizes, limited access, valves don't exist. So, what do you do for a child who's maybe 4 months old with an annulus of 12, 13? The smallest size is 16. Tilting the valve, very challenging surgically with lots of problems. There are always associated defects. The structural integrity of tissues is very, very poor. Trying to change a valve in an AV canal is a nightmare. The sutures just don't heal. Don't hold, not heal. And there's a need for growth. So even if I put in a valve in a 5-year-old kid, which is a 16 today, in 3 years' time, he's outgrown the valve. So then you go back again and keep changing it. Not done. So that is where the repair sort of came in. And as you would see that over the years, we have become much better at repairing them. And this is a 2006 registry. It has become even better now. So in about up to 90% of children, we would be able to achieve good competence of valves when we start doing them. We are very confident of dealing with the mitral, the tricuspid, and the pulmonary valves. Aortics are still a challenge, but even there, it's becoming much, much better. Just a few examples. I think so. There again, it's this all red is a regurg. Now that has been reduced to just that very thin whiff of blue. So what we have done is we've advanced the leaflets. And what I mean is that you detach the posterior leaflet totally and you sort of extend it with a pericardium or a 0.1 mm PTFE. Your apposition becomes much better. The coaptation depths become much better, and you get competent valves. Artificial cords also now pretty commonly used. Again, case of example again. So the leakage is sort of practically disappeared. So it should have been red there if the leakage was persisting. This is interesting. So Schoen's complex, form of frustrate, you have multiple lesions. So you have a VSD here. The mitral valve is small. And if you can see this thick thing here, this thick thing here is the cord, the structure which supports the leaflet. That's very thick and doesn't allow the leaflet to move. You also have an associated tight coaptation of the aorta. Schoen's was sort of, nobody would touch a Schoen till about a decade and a half back. And as we sort of become better at it and we're becoming more aggressive, we do them regularly. So that's an extended resection and anastomosis. You take away the whole abnormal aorta, which is kind of saw the serpentinous aorta. Whole of that has been taken away and you do an anastomosis there. The mitral valves, you take away the ring, you just cut it off. And then what we do is we split the muscle. So the thick subvalvular structure which is there, you can debulk it, which allows some amount of mobility to come in. You can also debulk the leaflets. What that allows us to do is that initially, before we started off here, the gradients was like a peak of 19 and a mean of 9. You'll never make it 2 and 3, which is normal, but you can get them down to a mean of 4. Now, the good thing is that if you look comparatively, even if you've stuck in a valve, valves will also continue to have mean gradients around 3 to 5. So not bad. Now, this allows you growth. You don't need to anticoagulate these children. And the functionality is much, much better than having a valve. As I mentioned earlier, arterial switch is pretty much standardized. You don't have to use your brains. Get them operated before 2 weeks of life. There's so many other techniques. If they come delayed to you, you can band it, you can train it either pharmacologically or mechanically. Expensive, very labor intensive, results are not good. The best thing is to get them operated before 2 months. Do you want me to continue? We abridge it. Sorry, some more. Okay. So you're willing for the pain, right? Okay. So this is what is known as a Brox. It's this is the aortic annulus here, and that 0.39 is above the valve. Now the challenge here is that they will be part of a syndrome, Williams. You will then also have, so those are just for gradients. You will have involvement of the pulmonary arteries also. So diminutive pulmonary arteries. So both the systems are obstructive. Immense amount of afterload for the right and the left ventricles. Both the ventricles tend to sort of fail. So you do what is known as a Brox. You take out that thickened area there. That's what you do, and you put in good tissue and you reconstruct. And this is what you can sort of achieve. So it's all laminar flow now. The whole aorta has been opened up. This child also had a mitral valve pathology. We were not able to repair it, so we've replaced it. Truncus, again, challenging. I mean, if you're not operating on them in the first 6 to 8 weeks, the child is going to struggle. You need artificial tubes to reconstruct the pathway. What becomes challenging is that sometimes the morphology of the valve, instead of 3 leaflets, you have 4 leaflets, and this valve will invariably leak. So if you can see them, I know most of the cardiologists will be able to pick up the 4 leaflets. That's the leakage. If you see here, that's the valve which is leaking severely. The challenging part here was that the pulmonary arteries were discontinuous. So that right now comes from the aorta. The left is being fed by the PDA. So there are non-confluent. This is a type 4, the most complex that it gets. We did a repair. So repair nowadays standardized. You remove the small component, you reconstruct it. The older techniques of repairing the valve and leaving it as a quadricuspid, he had a very high failure rate. Nowadays, it is pretty much standardized. It is technically challenged, but you do take away the 4th leaflet and you reconstruct it. And this is what you're able to achieve. Hardly any leakage. So again, if you're looking at it as a short axis, this center, this whiff of blue, is as good as a new valve. Again, a challenging case. Somebody had done a balloon in Turkey, and then the child had picked up infection, and then they'd got an aneurysm which was there, and here, and this was you could see the blood swirling and going by the z-scores. It was a z-score of +8. Sort of the stage was all set for an impending rupture, and so what we did was a ventral graft. We took it from the ascending aorta to here, just bypassed that area, and we went and ligated the 2 ends. Single ventricles, again, so some people may feel challenged. So single ventricle would be any component of the heart where the 4 chambers are not fully formed. Sort of it's now evolved. You need to intervene early. And an extra cardiac fontan is pretty much standardized now. Initially, the mortality used to be 30-40%. It's now come down to about 1 to 2% in most high volume centers. What has sort of become mandatory now is that they need to get into an exercise regimen. That has shown that the incidence of one-time failure on a long term goes down drastically. And people who have been exercising and in a regimented manner, their post-operative period is also very good. That's a tracheal stenosis. So this child was a child with diphtheria. Somebody stuck in a tracheostomy tube and then forgot to take it out. And the child floated around with a tracheostomy tube for 1 year. They were just not able to take it out. It's kind of separated here. So this is the proximal end of the trachea. This is the distal end. And that's the tracheostomy tube in the middle. So we do a lot of tracheal work also. So we'll not take you through all of that. Techniques. So once we have re-anastomosed it, we do a very, very crude test. Other than doing an endoscopy, you also just fill it up with water, and there should be no bubbles which should be visualized. If there are no bubbles, you've done a great job. And that's the endoscopy, which was done 6 weeks later. So this is known as a figure of 8 sign. 30% of people will have it. But as the child grows and it repairs in the next couple of months, this will disappear. So what you can actually see is you can see the 2 bronchi there, re-established, patent airway, and so that is what you can achieve. Technical innovation. So the biggest advantage that Max has is that you have all the subspecialties in one place. So I have the phenomenal advantage that I've got a general pediatric surgeon. We have a plastic surgeon who looks at children. We have plastic neurology, plastic orthopedics, so on and so forth. What that allows us to do is take on cases like a contrail. So that's an outpouching. The heart is lying outside here. That's a abdominal hernia. The sternum is not fully formed, and she also had a complex congenital defect. So we did a stage 1 Glenn on her, and then with the help of the plastic surgeon and the GI surgeons, we were able to reposition the heart back, and this is what you can achieve. Magic. Again, so hybrids, this is interrupted. So I'll just take one more case. So that's a VST there. You also have mitral stenosis in the same child. That's the gradient. So the mean gradient is 16, which is huge. It should be less than 2. I don't know how this child survived to this age. The valves are hardly opening. And that's the leaking valve on the left. And that's critical aortic stenosis. Now, all of these lesions can be dealt single stage surgically, but the morbidity load is huge. So what we did was that we went in for a hybrid. We stented the aortic coarctation. And that's the stent. So you open it up. We have not dealt with the PDA at this stage. Sorry. So if you notice, this PDA is still open. This was on purpose. We could have used a covered stent, which would have dealt with the PDA also. But since we were going up for surgery the next day, we chose not to address that. And that's a redilatable stent. So over the next 10 years, you can keep dilating it to achieve an adult-sized aorta. The tricuspid valve is repaired. There's hardly any leakage there now. So is the case with the mitral. And you're getting the gradients down to 6. Again, very small whiff there. We also do tumors. So that's a cardiac fibroma. The MRI scan showed it to be fibroma by the tissue characterization. we were able to debulk it, and you see the whole LVOT is now opened up. This was a 3-month-old child. I recently saw in Iraq when she's about a year and a half old. The tumor is not recurred. Fibromas are known to sort of disappear unless you have tuberous sclerosis along with that. So what is the present status? Any child with a congenital heart defect can always be made better. The functionality will always improve, and about 90% they can get back to leading an absolutely normal life. The 10% are the single ventricles, which will still need multiple interventions. And some cases, like the really complex ones where you have small pulmonary arteries, so even if you put a conduit, then you might have to go and change the conduit. The arteries don't grow. You need to keep going back and ballooning them and stenting them. So other than the 10 to 12%, the 85, 90%, extremely good results. Outcomes are phenomenal. So you're looking at a mortality of around 2 to 3% on a year-on-year basis, which is very comparable to the American and the European databases. So just to summarize, the child's interest is best served by a single total corrective procedure. Early intervention is mandated, determined by the hemodynamics. A referral to a dedicated pediatric unit is always preferred, and that to a high volume. And very gratifying early results can be got. And that's a collage from children from across the world. You can lead an absolutely normal, healthy life. And it gives immense joy to the surgical team as well as the parents to have them doing what a small child should be doing. Thank you so much.
Thank you so much, Dr. Dagar. Indeed, it was a very instructive presentation. Well, a few weeks ago, you may be aware we had a case here in Mauritius. It's about baby Ezekiel. So just to add another layer to tonight's event, it's the very doctor who did the surgery on baby Ezekiel in India, and baby Ezekiel is doing fine now. The treatment is ongoing, and he'll be coming back to Mauritius very soon. So moving to our next segment is the QA. No, so any questions for Dr. Dagar?
So Ezekiel is a child with a very, very complex congenital heart defect, which was diagnosed as a case of an AV canal. Now, to put things into perspective, if we're to go on a scale of 0 to 10, where 10 is the most complex, a AV canal would come somewhere between 8 and 9. The complexity for Ezekiel was compounded by the fact that she also had a Down syndrome, which makes the postoperative course.
If the child comes to us within the first 2 weeks, the first interrogation with the family, there are advised surgery. Most of them would agree. And so if like the child is coming to us in the first week, saturating around 60-65%, we would neither give the prostin. The problem with the prostin is that the texture becomes very friable. So when you're ligating the PDA on a child who's in prostin, there's 10 to 20% chance that will fray and it'll tear. Sutures don't hold well. Plus all the complications, the GI complications and the respiratory complications of prostin, we would try and surgery, and they should be taken up as early as possible.
You don't prefer waiting for a certain week to just act directly?
So like I said, we are very comfortable with anything above 2.5 kilos. So the ICU stay can become challenging, but the end result of survival and patients going home stays the same. For us, the only challenge that we have today is sepsis. We just don't have a handle on that, and especially for children who are coming in from overseas, it can be a nightmare for us for some time. So without naming a country, we had a string of kids. Preoperatively, CBCs, CRPs, procalcitonin, etc., all normal. We, as a protocol, will wait them out for 3 or 4 days before we take them onto the table. Everything normal. Day 1, platelet counts. Day 0, 3.5 lakhs. And Dr. Rayaz is witness to that. Day 1, 30,000. Just no way we could sort of deal with it. And then all of a sudden, around 12:30th day, the platelets start turning around. We eventually narrowed it down to a virus. But as you know, antivirals generally don't make too much of a change once they've been onto bypass. So all the patients that we lose, or most of them that we lose, is secondary to ongoing sepsis, where we are forced into operating on them without sort of stabilizing them preoperatively. Where we have the opportunity, we would. There's a very interesting study from the Canadian Pediatric Society, which says that if a child has a virus and post treatment of the virus, you should at least wait for 2 to 3 weeks for the endothelial function to come back. And if general thing is that, okay, no fever, no nothing, no cough, child is okay, the counts are fine, take him up for surgery. It's a disaster. We have burnt our fingers any number of times. That is very good advice. Please wait them for 2 to 3 weeks. So if you are ever transferring a patient to an overseas setup, please make sure that the sepsis has been taken care of. Rest, everything is manageable. Sepsis is not.
Thank you.
Dr. Shafa, any parallel with cardiac imaging?
Thank you. Thank you so much for your presentation and huge experience for children. Just a question for the monitoring of what's the deadline of the repair valve and replacement, for for the children and childhood and adolescence? If how many? For example, some valves. I know the quality of these valvules. What's the deadline? 10, 15, or 20 years? And how you have, for example, the monitoring of these children when they will be adults, and
Right.
What's the monitoring of the survey there?
Right. So I think there should be 2 components to this. Like I said, mitral tricuspid valves. We're very, very confident of dealing with them. And even within the mitral subset, the leaking valves, vis-a-vis the stenotic valves, do much, much better. Aortic valves still a challenge. So if you, again, a leaking valve is easier to treat than a stenosed or a bicuspid valve. The results with the pericardial replacement of the leaflets, the so-called Ozaki's technique, and the other techniques which have come out of Boston, initial results are extremely good. So you can get competent valves, but then they tend to deteriorate. And so in the next, 5 to 6 years, there'll be a leakage of at least a 3 or a grade 4, which is nearly severe in about 40 to 50% of children with an aortic subset. The other subsets like a VST and a cusp prolapse, so they by resuspension, etc., and the other techniques, generally very good results exist. Mitral tricuspid, excellent. Pulmonary valves, initially we used to do the monocusp. Again, would do very well in the immediate post-op, but then they would start leaking down the road. So we have now shifted to doing bicuspid repairs. Results are much better. They're more competent. And the immediate post-op leak quantum fraction is also less. All of these children would need to be followed up. So when they are overseas, so we stay in touch with the local partners. So the protocol that we follow is that in the first year is going to be an every 3 month echo review. And then if it's holding till the first year, then it increases to a 6 monthly and then probably an yearly till they reach adulthood. At any point of time, if you find that the stenosis or the leaking is increasing, then depending on the ventricular function and the physical capability and the clinical scenario, we might reduce it to a 3 monthly or a 6 weekly interrogation for these children. Preference is that if they come to you at a stage where the annulus is not good enough for an aortic valve, we will offer them a redo surgery. If you have got them to a stage where the annuli are good enough, then we would offer valve replacement. Some parents would still want to give another shot at repair, so we would do that. Where they're comfortable getting it replaced, those are also good options. The initial challenge used to be that valve replacements in children carried a higher mortality. That's getting blurred now. And if you have good stabilization and the ventricular functions are preserved, excellent results even for valve replacements. Anticoagulation is a little challenging for these children, but they somehow seem to do well once they've the parents have been put on board. And nowadays you have domiciliary systems to manage the INRs. So with that, the incidence of bleeding and coagulation anomalies has become minuscule.
Thank you. Any more questions?
So once again, good evening, Doctor. I'm Yogesh Rai from
Good
Welkin.
evening.
I have a question regarding major development in medicine. You talk about fetal echography.
Cardiography, yes.
Yes. I wanted to know a little bit more. What is the indication for a fetal echography, and in what cases we see the abnormal to be referred for? Because usually we go to gynecologists.
Right.
Just listen to the heart rate, and the doctor will tell you, "Oh, madam, everything is fine."
So it's pretty straightforward.
Yes.
Every pregnancy should have a fetal echocardiography between the 16th and the 20th week. 16 to 20th. There's a reason for that. In India, we are not allowed to abort after the 20th week. And it's also the safest at that time. So if it's a very, very complex and scrambled heart, we might suggest an abortion. Or if there are other chromosomal anomalies which are coexisting. So it cannot be tailored to a pregnancy. The best results are that if you make an SOP, that every pregnancy will have a fetal echocardiography. So the gynecological evaluations will, the stage level 1, 2, 3, all that will continue. But every child, every gravid mother or a pregnant lady will have a fetal echocardiography between the 16th and the 20th week. That's a standard practice nowadays in India.
Standard-wise, not for late pregnancies or
No. Every
are more at risk for.
Every single pregnancy will need a fetal echocardiography at 16 to 20 weeks.
Okay.
That's the only way to stop them from slipping through the net. If you go and leave it on an arbitrary thing or try and narrow it down, that if this exists, then we will get it done, you will miss a lot of children with congenital defects. It's becoming pretty sophisticated, so in good hands with good volumes. They have about a 90% accuracy at picking up most of the defects. 10% 5 to 10% they'll still miss, or the diagnosis will change in the immediate post-delivery period. But 90% they are 100% accurate.
Thank you.
You're welcome.
Any more questions from the audience?
Yes, one here.
Good evening. Thank you very much. This was really a very interesting presentation.
Thank you.
My name is Dr. Subida. I'm a pediatrician and neonatologist working in Mauritius. I just, first of all, want to give you an insight in the situation in Mauritius for newborn with critical congenital heart disease. For me, as a pediatrician, and I have my colleague here, Dr. Takan, who's also a very experienced pediatrician, having a newborn baby with critical congenital heart disease is one of our worst nightmare in Mauritius. I have been working in Mauritius now for 27 years, and I can say in the past 27 years, we have made zero progress regarding the management of a newborn with critical congenital heart disease. We can move to diagnosis, we can stabilize the baby, and all we have is frosting, we can ventilate, and that's all we can do. Only recently, Keeping Cardiac Center in Pamplemousse, I don't know if there's anybody here from Cardiac Center, they have been able to do balloon atrial septostomy successfully, and I think they've had 2 successful balloon atrial septostomy, and that's about it. So once we've stabilized the newborn and started the frosting, then it's this mad rush to try and get the baby to India. And not easy at all, actually. So I'm just sharing this with you to see how you can help us. I work in private healthcare, and where I work, we have had cardiac surgeons from India who've come to work for us, who had sort of double skill with adults and newborn and children. But after a while, they get fed up because they say the workload is not high enough for them to stay here. They're going to lose their skills. So this is the problem we've had. So basically, we're back to square one. So that's one thing I wanted to share with you to see what you can do to help us.
I empathize with you totally. I've lived that kind of a scenario. We've been through this all. So till about very recently, which I would say in time frames is about 2-3 decades back, we had the same kind of challenges. And these challenges still exist in India in places which are far removed from the metros. The diagnosis would get made, and then for various reasons, the child will not travel for surgery. So the challenges are very real. They are sort of heartrending. So one of the ways to sort of deal with it is to increase awareness. Second is educating people, and third is to build teams. You may have the best surgeon in town, you can have the best cardiologist, you can have the best intensivist, but unless these guys are talking to each other and they are on the same page, nothing is happening. You'll always be square one or maybe square zero for the rest of your life. So that is a challenge which we've sort of overcome, and why we were able to overcome it is that all of us sort of traveled abroad to sort of fine-tune our skill sets. And the only thing that we found which was acting differently there was not so much the surgical skill set, but the way that the teams worked and the way they sort of integrated with each other, and then the layers which are sort of built one on the other. So if it slipped through one layer, the second one would get it, the second messed it up, and the third would get it. So if I were being asked for advice, it'll have to happen at multiple levels. The government should have the gumption to be willing to invest education, training, skill set development, and building of teams. There is no shortcut for this, and this is a progress. It's a journey. It's not that you go to bed one night and get out of the right side of the bed and tomorrow everything's sorted. No, it will need to evolve, and this is going to take time. Having surgeons coming in here and operating is not the solution. It never will be. We have done that any number of times in Afghanistan. We've done it in Iraq. We've done it in a few places in Africa. You go in and you're taking the whole team. I mean, it's amazing that you do fix a VSD and then the child comes out, and then they're struggling. You tell them that, please, can you give us this medicine? Oh, it doesn't exist in the pharmacy. So, okay, so now what? So you can't carry everything with you, the basic infrastructure. So where we can help you is to help you in training. So we are more than happy to train the nursing staff. The surgical training is a little more challenging because unless you are into an accredited program, you will not get any hands-on. But cardiology and intensive care, you live with us, and the advantage that you get is the scope of volumes. So the higher the volume in a center, the more you're exposed to complications, and since we have a team which is there in place, you learn so much more. So an intensive care person's perspective will be very different from what a surgeon is going to carry. Surgeon is always going to be biased since he's operated on the case. It doesn't happen. But then you have to trust your intensivist. He'll tell you, no, this is not working. This is what it is. The cardiologist will show you the echo and tell you, see, this is where you messed up. And the intensivist will then come and tell you, okay, I can bail you out, but then you have to follow the lead. So then the surgeon goes at the back of the chain. So you need to trust each other. You need to trust and you need to build teams. Unless team building happens, there's going to be no movement. And on a very short-term basis, I think you will still have to establish one-on-one contact with the centers which are at a higher level. And the only way to help them is to transfer them out as early as possible. And then the teams, so the work has to start now. So like we were discussing in the morning, so you got to begin before you're ready. You can't keep saying that, okay, first the government has to do this, then I have to do this, that this thing can happen. No. One person has to wake up one day in the morning, say, okay, fine, I want to do this, and I'm going to start, and then let the other people come and join the bandwagon. So you need to take the hit, you need to carry the cross, but that's the only way to do it. And that's the way we've done it. And every single center in the world has gone through that pathway. You can't avoid the pain. If you're not willing to take the pain, nothing is changing.
Anyway, we're very grateful to people like you who look after these babies, and we've had quite a few of them who've come back, after a
Thank you. I
successful
think it's a
surgery.
blessing, and I feel very, very privileged to be able to help these children. And thank you so much for trusting us. Thank you very much. Thank you.
Okay, Taslim, can Omka be a platform for this procedure? Please elaborate.
Thank you, Ashraf, and thank you, Dr. Dagar, and thank you, Dr. Sabada, for your question you've been asking. So what we are developing also right now in Mauritius is a training institute. So with our partners in India, Turkey, and Saudi Arabia, so we're building a training institute which will be available in next 6 months, where the training institute will be able to train the surgeon, doctors, and specialists will be able to come to Mauritius and able to make like program for 6 months or even 1 year. We start from Mauritius and then we go to India for about 1 month or 2 months or 3 months, depending upon the program. And then it will be able to bring the bridge between Mauritius and India, where our doctors and nurses also is going to be a fully medical training institute, where it's going to help out in our capacity. So our mission is being always to help patients to have the treatment immediately. For us, there's no competition in healthcare because we want to do something for someone who need a treatment immediate. So that's why you see that Max and other our partners hospital we have in India or other countries. So with that training institute, I'm sure that is going to help some doctors to be able to increase the level and also do things here in Mauritius itself. Because sending patient to India, like Dr. Dagar said, is like India also have the same problem. So I'm in India, Omka, Overseas Medical Care, also based in India. We are supporting patient also in India. So the centers that in like Delhi, Mumbai, they are good areas, or even Bangalore. But the area where there's no medical facility is the same. So India is a very big country. And then what we have to do, we have to invest, we have to do things like to save the babies, to bring them nearest to the hospital, like Max or other hospital. So the problem is, it's not a problem only for Mauritius. It's a problem it's happening around the world, especially Africa. When we talk about Africa, Mauritius, we are very lucky. We are African country, but the cardiac surgery, the cardiac unit we have in Mauritius is very, very powerful. And because they've been investing in cardiac surgeries, there's a lot of investment in cardiac surgery in Mauritius. And when you go to Zimbabwe, there's only one cath lab for the whole population. So imagine, so how lucky we are in Mauritius also, even we're able to bring all these doctors here easily. So in Africa, we're not able to do that. But we start with a training institute, and hopefully this will help us, our nurses and doctors, to be able to train ourselves with a specialist there in India. That is like what is in the plan for us. Thank you.
Thank you very much for our speakers. Thank you so much for the doctors, Max Hospital.